Hi guys, this is a really short video. In talking to some of our neurology experts and pathology experts, we realized that we had kind of a gap in the curriculum. We teach you about Guillain-Barre syndrome, which is basically an acute immune-mediated polyneuropathy that basically leads to this monophasic paralyzing disease. And there are a whole bunch of different types that I'm going to let all the neurology people talk to you about. But previously, I've never really taught the immunology or the microbiology behind Guillain-Barre syndrome, which is kind of funny since it's an immune-mediated syndrome that is caused by a microorganism. So to rectify that gap, I'm just basically going to create a video that just focuses on those. If you want to know anything else about like the pathophysiology about it or anything like that, seek out your neurology discipline directors and they'll be able to give you more information. Okay, so I'm teaching this in the same packet that I teach multiple sclerosis as well as JC virus, which leads to PML. So basically what that tells you is that we're talking about a whole bunch of diseases that lead to some sort of damage to myelin or have something to do with a microbial organism. So in this case, they're showing C. jejuni that leads to basically inflammation and immune dysfunction in the brain. Okay, so we're talking about basically how does the immune response get it wrong and mess up the brain. That's kind of the whole crux of this. And if you look in this packet, or if you're watching online, if you look at my multiple sclerosis video, you'll see I talk about a concept known as molecular mimicry. And molecular mimicry is actually also really important when we think about the disorder or the syndrome Guillain-Barre. Basically, the most common proposed mechanism for Guillain-Barre is a predisposing infection. So you need to have had something that kind of jump starts things, like kicks this whole thing off. So basically what happens is you have this predisposing infection, and that leads to an immune response which cross-reacts with peripheral nerve components that basically share antigens with the pathogen. Basically, in most cases, the immune responses are directed toward myelin epitopes or the axons of the peripheral nerve. And that's why you see kind of this polyneuropathy, because literally you may have created these immune responses towards something that was harmful, like C. jejuni, but now it's attacking your normal healthy tissue. Immune responses that are directed against epitopes in Schwann cell surface membranes of the myelin can cause like an acute inflammatory demyelinating neuropathy, AIDP, which is kind of one of the more common presentations of Guillain-Barre, but there are other ones. The pathology is multifocal, and you can see demyelination starting at like the level of the nerve roots. Earliest changes are going to be seen at these nodes of Ranvier, where basically you've got this attack happening here between where the Schwann cells would have protected the myelin. So back when I used to study MS, I used to think of Schwann cells as like the plastic coating that protects your headphones. So I wear headphones a lot. You guys see them in my videos, right? A lot of times I just kind of crumple them up and put them in my pocket. And eventually this like plastic coating will start to get like little breaks in it, right? And then the wire is exposed. So instead of the wire being nicely coated and the signal being carried or propagated along, now the wire is exposed between the ends where this rubber basically broke, and now it's, you know, I'm losing some signal. Well, you can think of this with Guillain-Barre a little bit differently. If we had these breaks already because the Schwann cells weren't completely covering it, that peripheral nerve axon is now more available to be attacked by the immune response. And there's no one specific member of the immune response that's going to cause damage. T cells, macrophages, complement, antibodies, they all come into play. So we're going to make cross-reactive antibodies, and The reason that this image is showing C. jejuni is that C. jejuni is actually the most commonly associated with Guillain-Barré syndrome. And you first learned about C. jejuni back in your host defense, host response course in the Jenna Wilson case. So there are some videos for C. jejuni on my YouTube channel if you want to check that out. C. jejuni, you might remember, is a gram-negative organism. And instead of having LPS, which most gram-negative organisms have, it has lipo-oligosaccharides. And in this case, the gangliosides for the lipo-oligosaccharides are very similar to a couple of gangliosides that are associated basically with our peripheral axons. And that's why you get these antibodies that are cross-reactive for Campylobacter and our own bodies. So the antibodies are only produced in patients who develop Guillain-Barré syndrome. Patients who do not develop Guillain-Barré syndrome don't develop these antibodies. So we don't necessarily see those unless the patient is actually going to develop them. So what does this tell you? Well, it tells you that in order for you to actually come down with Guillain-Barré, you have to be really good at making immune responses to C. jejuni or whatever other infection is being associated with the development of Guillain-Barré. So you have to have a functional immune response. You have to have helper T cells that are going to help the B cells become plasma cells to make the antibodies. If you have helper T cells, you have really nicely activated macrophages that are going to chew away at either the myelin or the nodes of Ranvier, or the axons that are exposed there. Complement is going to be recruited because we have inflammation. When we have complement and we have antibodies, we've got a party, or at least an inflammatory party. So what infections are actually associated with Guillain-Barré syndrome? So the answer is a whole bunch. I've already talked a little bit about C. jejuni and the role that that one plays, so you can think about that for the previous slide. But things like HIV. HIV has been associated with Guillain-Barré. Now, we haven't talked about this much yet. We will a little bit later. But there's a whole host of neurocognitive and motor disorders that are associated with HIV infection. Basically referred to as HAND, HIV-associated neurocognitive disorders. And then there's also minor cognitive motor disorders that are associated with HIV. We'll talk about these a little bit later, but what it basically tells you is that HIV could be associated with just kind of this abnormal inflammation, right? But remember, one of the key things about Guillain-Barré syndrome is that you actually have to have an effective immune response, because this is kind of like an overactivation of the immune response. So what this tells you is that just because your HIV patient is well controlled and on a therapy regimen that is, doing well by them and they have a good CD4 count, they are still susceptible to GBS because they still have all of the components of a good immune response, which is what we need to develop in GBS. Influenza and other influenza-like illnesses. GBS has been associated with recent infection with flu, as well as other things that make us feel like we have the flu, but we might not. Ones that have been really associated with are EBV and CMV. EBV is actually a fun one because EBV has also been associated as a potential etiologic agent that might lead to the development of MS, which, as we know, is another demyelinating condition. But basically these influenza-like illnesses. The other reason I say influenza-like is that everybody who feels flu-like doesn't always run to the doctor. Even though many of you who become doctors may feel that that is the case, not everybody with a flu immediately runs to the doctor. So many of those illnesses will have gone undiagnosed. So what you have is you have a patient who you think has GBS, and you might ask them, in the past month or two, have you had any flu-like illnesses? Have you felt sick? And if the answer is yes, it's possible that whatever they had actually put them at a higher risk of developing GBS. Along that same vein, Zika has been associated with GBS development. Remember, Zika does cause kind of non-specific flu-like symptoms. Like many things with Zika, this association is somewhat new. So even though Zika is not a new virus, some of the things we're finding out about it are a little new. So the relationship has not really been firmly established, but it is rumored. Okay, vaccination. What's the deal with vaccination? In rare cases, vaccination has been associated with an increased risk in GBS. To speak specifically about it, in 1976, there was an increase in GBS risk, specifically with the swine flu vaccine that they were using that year for the seasonal vaccine. A similar small risk happened in 2009 with the H1N1 vaccine. So, there are these small elevations that we see. However, you should still get your flu shot, because here's the thing. Remember up here, influenza-like illnesses are a risk factor for GBS. There's this small risk, maybe 1 to 2 greater cases with vaccination per million people for developing GBS. But if you get infected with the flu, your risk for developing GBS is so much more than if you just got vaccinated for the flu. So much better to get the vaccination. You not only avoid getting the flu, but you also reduce your risk of influenza-induced GBS from a vaccination than you would get if you actually got the flu. Does that make sense? Either way, get your flu shot. Okay, those are the main take-home points.